I see that there is a lot of people with from India. So good evening, everyone. I'm very happy to be there, and I hope that everyone can hear me quite well, and that you will understand my English. So first of all, I would like to thank all the organizers of this webinar. It's a very good opportunity for me, and I hope that you will enjoy the hour with me about cruciate disease. The purpose of the presentation is to describe the diagnosis and the treatment of the cruciate disease in dogs. I am a consultant for Matrix, Novtech, and Portvet it's the small animal orthopedics field. But for this specific presentation, I did not get any disclosure. As you know, CCL rupture is one of the most common orthopedic conditions in dogs. And of course, knowledge of clinical and radiographic sign is mandatory for diagnosis. And at that time, TPLO is clearly the standard of care for the cruciate disease. And so the purpose of the presentation, by following the story of Venus, a Rottweiler, is to describe the clinical and the radiographic signs of CCL rupture and to describe the principle and the outcome of TPLO surgery. First of all, history of Venus. Venus is a Rottweiler, female nurtured, 4-year-old, which is quite always the same thing for the cruciate. Most of the cruciate disease would be in the large breed dogs, Labrador, Rottweiler, Cane Corso. Most of them are between 5 to 7 years old, but in Cane Corso and in Rottweiler, you can get very young dogs. I get some dogs from 8 to 10 years old, where you get some cruciate disease, often bilateral, and the spayed female are clearly overrepresented. There is a lot of much more spayed female in a cruciate disease compared to the male. Venus is presented to the clinic for acute right hind limb lameness since 3 weeks. There is no history of trauma, which is different in cruciate history, is that you will get several type of presentation. I think that you can see two type of presentation. The first one will be the acute one, where the trauma is often minimal, but the dog was very limp, very limp. There is a lot of pain on the dog. Most of the time there is a huge instability of the stifle. But you can see in perhaps 7 to 70% of the cases, chronic case of a cruciate, where you will get progressive lameness with more osteoarthritis and less stifle instability. Be careful, because in 10 to 20% of the cases, the problem will be bilateral. And bilateral problem will be more in large breed dogs compared to the small one, but it's quite often that you will get a Rottweiler or Cane Corso or overbred like that, where you will find both of the stifle with effusion and with cruciate disease. As a key point for the history, I think that you need to keep in mind that the cruciate disease will be more often in large breed dogs. Spayed females are overrepresented, and most of the time, the cruciate disease is without any trauma. There is a degeneration of the cruciate. It's a very degenerative disease, so we call that a cruciate disease. Not only a cruciate rupture, but it's a disease of the stifle. The diagnosis of the cruciate is clearly sometimes difficult, but most of the time with only a good orthopedic examination and with good x-rays, you will get the diagnosis. And this is Venus. Venus gets this presentation, and you can see that on this video, he gets his weight is more on the left limb, and the dog is shaking his right limb because it's painful. And you can see this clearly movement of the right limb. And when the dog is walking, you will see that there is a clear, I think, at least grade 3 lameness on the right hind limb. It's quite evident to see, and most of the time the diagnosis is quite easy because the lameness is quite evident. But for the cruciate, you can get all type of lameness. You can get some very lameness from grade 1 to grade 5. You can see on this small dog a lameness on the right hind limb also, which is clearly evident. And you can see also very much more specific lameness on this one with a grade 5 lameness on this very small dog. But in some case of partial cruciate rupture, you can get very small lameness. And you can see on this German Shepherd that there is a very small lameness on the left hind limb, which is because of a partial cruciate rupture. So I would say that lameness on the hind limb is a cruciate unless you find other thing. So as soon as the dog is limping for the hind limb, you should think about cruciate disease. On palpation, the stifle of the of Venus is enlarged. There is amyotrophy of the right hind limbs, and you can see on this picture that there is in this dog there is a medial buttress on the right stifle, and you can also feel that there is a jaw effusion. In those dogs where there is a stifle effusion, the patellar ligament is very difficult to palpate. You don't feel it at a very easily, and most of the time the patellar ligament is ill-defined. So that make you think that you get a jaw effusion. That's the two first points you are going to palpate: medial buttress and jaw effusion. And you see to the literature, which is very specific and sensitive sign to because of the cruciate disease. You can see that patellar tendon palpation is very sensitive and very specific, and also the medial aspect palpation is quite very specific and very sensitive in those in this paper. So you can make you feel that just by palpation, as soon as you get medial buttress and jaw effusion, you need to think about a cruciate disease. In order to be able to see this difference of both stifle, you need to palpate the stifle as symmetric as possible, and the palpation should be bilateral. Which I like to get is the dog is like that, with my two hands in both stifle, and I can feel that there is any difference from the right side to the left side. It's very important to do bilateral palpation and very symmetric palpation to find any subtle modification of the stifle on those cases of a cruciate disease. On mobilization, the dog is painful is in extension with Venus, and you can see that there is a subtle positive drawer test in the direct one, which is not very easy because it's a large dog. It's a very stressed dog, so not so easy to palpate. And my advice will be, as soon as you get it adopt, you need to put the dog into general anesthesia and to do the drawer motion under general anesthesia. And you can see that there is clearly much more easy to see the drawer in this when the dog is sleeping. My advice for the drawer is always to start with the caudal motion of the tibia to put the tibia in the right position, and then to start with the cranial drawer test. That's most easy in the clearly much more easier in a dog which is sedated. The tibial compression test is also a very interesting test. It's you need to keep the dog with the stifle in a comfortable extension, and then you are going to flex the tarsus. And you can see that when you are going to flex the tarsus, there is some drawer motion and there is some advancement of the tibial crest. You can also get the same feeling with the dog under general anesthesia, and you clearly see that there is the advancement of the tibia when you are going to palpate this dog and when you are going to do the tibial compression test. When the dog is not sleeping, I get the feeling that the tibial compression test is better compared to the standard drawer test. But in the study, which I showed you last time, that there is not clearly difference between the two tests. Most of the tests are very sensitive but very specific. As soon as you get this test positive, you are sure that there is a cruciate rupture. But sometimes the test will be negative in partial tear. You see that under sedation, you clearly increase the sensitivity of this test. So I would advise you, as soon as you get in doubt with a cruciate, put the dog under general anesthesia and palpate the dog under sedation. That will give you much more easy to see the instability of the stifle. In this dog, in Venus, I did not get any meniscal click at the time of the palpation. The meniscal click is when you are going to palpate and flex the jaw in multiple directions. You can hear some clackmuck just like that, which is give you a highly suggestive of meniscal tear. Most of the time, the meniscus there is a rupture of the meniscus. The meniscus is coming from the back to the proximal part of the tibia, and then there is a clear click at that time, at that moment. But be careful, these meniscal tear are only associated with a meniscal click in more or less to 20 to 30% of the cases. So if there is no meniscal click, you cannot rule out a meniscal tear. The key point for the orthopedic exam, I think, for the cruciate is to think that, of course, there is a lameness, there is a medial buttress. Other dog with a stifle injury with a cruciate disease get medial buttress and patellar tendon effusion. And most of the time, you also get some pain upon extension. And this is clearly what you will get in the partial tear. The partial tear, medial buttress, patellar tendon effusion, and pain upon extension. That will give you a very strong suggestion of there is a cruciate in this dog. It's very high suspicion of cruciate disease when you guess with those clinical signs. Of course, as soon as you get a drawer test, it's pathognomonic of cruciate disease. But be careful that this drawer test could be minimal or absent in partial tear. I would advise you to put the dog under general anesthesia to be more sensitive with the drawer test. You can do both tests. Usually I do both tests, the standard drawer test and the tibial compression test. But I think that you need to find the test which is more confident for you. If you do prefer the tibial compression test, keep the tibial compression test. If you do prefer the drawer test, keep the drawer test. But most of the time I do both because I can compare both of the tests. If you get suspicion of this of cruciate, you need to go to X-ray to confirm your diagnosis and to see what's going on in the stifle. Why X-ray is important? First of all, X-ray is very sensitive and very specific of cruciate disease, so that will give you very confirmation of your disease. But also, it's very important to rule out any other problem, to rule out tumor, to rule out any fracture, and also to get a good joint evaluation. You can see how many inflammation there is into the joint, and you can see also how many osteoarthritis there is into the joint. How you are going to do your X-ray? Your X-ray need to be under general anesthesia to get good and very beautiful X-ray. You need at least a lateral view, and you need also a codocranial view of the whole tibia. It's important to do the whole tibia just because that will be very important to plan the surgery and to get the whole tibia to plan your TPLO surgery after that. What are you going to find in dog with cruciate disease on X-ray? First of all, you are going to find some secondary sign, and you can see on venous that there is some osteoarthritis. There is clear osteophyte around the joint, and you can see osteophyte in the patella, around the fibula, around the tibial plateau. There is osteophyte. I think that in 80 to 90% of the dog. Most of dog with a cruciate get osteophyte in the stifle. You also find some effusion of the stifle, and you can see that there is on the codocranial view that there is medial buttress on this tibia. You can see also in the lateral view that there is what we call the fat pad side, that there is effusion of the joint, and we did not see clearly well the fat pad as it should be. And there is also dilatation and enlargement of the stifle in the caudal part of the joint. The fat pad side is based on a lateral view. You see on the left side a normal standard X-ray, and you see that you clearly see the fat pad. The fat pad is more or less black, which is the fat density in X-ray. But as soon as you get a joint effusion, you will get some augmentation of the synovial fluid, and the synovial fluid will push the fat pad and compress the fat pad to the patellar ligament, and you can see that the fat pad is clearly smaller in a dog with a cruciate. And you clearly see this effusion into the stifle. And effusion plus osteoarthritis is highly suggestive of cruciate disease. Second, and you can see that the fat pad on the left side is quite large and very small in the right X-ray from venous. You can also get some sign of instability with the X-ray. The sign of instability will be based on the lateral view. You see that there is the tibial eminence is not centered around the condyle of the femur, and you can see also that the caudal part of the tibia is not. Oops, sorry, I get a problem with the. Oops. Okay, cool. And you can also see that there's a cranial displacement of the tibia, that there is a caudal part of the tibial plateau is not aligned with the caudal part of the femoral condyle. This is what we call the radiographic drawer test. And you can see that this dog, which is venous, you can see that the joint instability, osteoarthritis, joint effusion, there is a cruciate in this dog. It's clear based on your examination and based on the X-ray, there is a cruciate rupture. So I think that the key point for the X-ray would be secondary sign. Think about osteoarthritis. Think about effusion with the fat pad sign, and you can see that all those joints get cruciate. Low X-ray for low osteoarthritis, but huge effusion in venous. In the other part, there is more osteoarthritis, but there's still some effusion. In this stifle also, there is few osteoarthritis over there, a huge effusion. And this stifle, we get low effusion, but a huge osteoarthritis. And in some cases, you will get also a radiographic drawer as it is in the venous cases. So I will say that with with a good physical examination and with the radiographic side, you will get in 99% of the cases a diagnosis of cruciate lesion. If you get any doubts about the cruciate disease, I think that you can move to three kind of complementary exam. First of all, ultrasound, which is quite easy to perform, but not very easy to interpret. And you need very good ultrasonographists to see the cruciate and to see what's going on into the stifle. Of course, MRI is still the gold standard in the human field, but not so available in the vet field. And in my practice, I do prefer the arthroscopy to confirm the lesion. So I go to arthroscopy, and if there is any lesion, I do the surgery. Yeah, I do the treatment of the cruciate at the time of arthroscopy. So my favorite secondary exam is arthroscopy to be sure of the diagnosis for cruciate disease. You get the diagnosis of the cruciate disease. So at that time, you need to go to a treatment. For venous, we choose to go to a TPLO. The TPLO is at that time the gold standard for the treatment. What could be the other option for treatment of the cruciate? First of all, you can still go to medical therapy, but the medical therapy is associated with persistence of lameness, increased risk of osteoarthritis progression, and the outcome is not as good as it should be compared to the surgical treatment. So I would advise to go to surgery in all the cases you get with a cruciate disease. If you don't want to go to osteotomy, you can still keep to a extracapsular or intracapsular suture. Extracapsular suture, which is perhaps the most performed surgery for the cruciate, is associated with sometimes with a rupture of the prosthesis, and so persistent instability, progression of osteoarthritis, and still lameness. The intracapsular suture are less performed currently. There is some work on the intracapsular suture. This is a gold standard in human being. So there is still some work about intracapsular suture in the vet field because we would like to get perhaps a less invasive and more arthroscopic surgery for the cruciate. Of course, there is a lot of other tibial osteotomy, such as the TTA, such as the CCO, the CCWO, and the CBLO, which is the lastest one. I would say that in my hands, I almost always perform a TPLO because it's for me the best, the more reproductive surgery for the cruciate disease. Uh, Currently, TPLO is the best treatment option because there is the best recovery. There is less pain, less lameness at the end of at 6 months after the surgery compared to TTA, compared to extracapsular suture, and also there is less progression of osteoarthritis. So in my hands, I do for TPLO in most of the cases. What is the principle of the TPLO? Compared to the extracapsular to the intracapsular suture, where you are going to replace the cruciate with a prosthesis, in the TPLO, you want to eliminate the cranial tibial thrust by decreasing the tibial plateau slope. That means you do not want to replace the cruciate, you want to eliminate the need of the cruciate. If you look at the stifle, you will get in peak the joint reaction force over there, which could be separated in the cranial tibial thrust, which is parallel to the tibial plateau slope, and the compression force, which is perpendicular to the tibial plateau slope. So if you decrease the tibial plateau slope and you keep the slope to more or less to 5 to 6 degrees, you are going to align the compression force with the joint reaction force, and you are going to eliminate the cranial tibial thrust. You won't get any more cranial movement of the tibia. That's the purpose of the TPLO. We do that with a proximal cut of the proximal part of the tibia, and we are going to rotate the proximal part of the tibia and to put some bone plate to be sure that everything will be stable after the surgery and the healing will be okay. Sorry, I did not. I cannot go to other slide. Oops, sorry. Okay. When you want to go to a TPLO, you need to plan your surgery. It is very important to do a very good planning to the for the TPLO, and to see that for Venus, we plan for the measurement of the TPA, and we plan for the position of the osteotomy. You can see on this video how the planning is done. And the planning is done first with what we call the functional axis of the tibia, from the proximal part onto the distal part of the joint. And then you are going to measure the tibial plateau slope with the proximal part of the tibial plateau to the caudal part of the tibial plateau. And you see that the measurement of the tibial plateau angle in this case this will be 29 degrees. So how you can do that? You are going to take the center of the tarsus, the tibial eminence, which will give you the functional axis of the tibia, and then you are going to draw the tibial plateau slope from the proximal part of the tibial plateau to the caudal part of the tibial plateau, and that give you the tibial plateau slope. Of course, it's also important to put your osteotomy position during the planning, and you are going to select the size of your saw, and you are going to put your saw in the center of the tibial eminence to be sure that you are well positioned in the proximal part of the tibia. Before to do the TPLO, I always do a joint exploration of the stifle, because I would like to confirm the diagnosis in case of any doubt. I would like to evaluate the cartilage to see how much osteoarthritis we get. But most important, I would like to evaluate the meniscus. You can do that with arthrotomy, just like with this picture, but you can also do it with more minimal invasive approach with an arthroscopy. And in my hands, I do prefer the arthroscopy because the diagnosis is better, and it is clearly less invasive compared to the arthrotomy. You can see on this picture of the surgery of Venus that you get a very beautiful rupture of the cruciate. You can see the back of the cranial cruciate, the caudal cruciate one, which is quite normal in Venus, and you get a very complete tear of the cruciate in Venus. When you are going to palpate the meniscus, it's important to see the meniscus and to probe them, and to palpate them. And you can see that in this during Venus arthroscopy, we go to the medial meniscus, and you see that as soon as you probe the meniscus, you can see the tear. There is a medial a bucket on the tear in these cases, and you need to do a meniscectomy for this problem. You need to remove the the part of the meniscus which is the damage in order to avoid any lameness after the surgery. If you miss this tear, you will get some lameness at the end of the TPLO. You will get poor outcome after surgery. I think that it's clearly more interesting to do it in all the cases with arthroscopy because there is meniscal tear in 30 to 40% of the cases of cruciate disease. And arthroscopy with probing of the meniscus will give you uh, a better chance to diagnose the meniscal tear. If there is almost twice the likely to detect the meniscal tear with arthroscopy compared to an arthrotomy. So that's why I do prefer to do an arthroscopy compared to an arthrotomy to explore the joint before the surgery. As soon as the joint exploration is done, we move to the TPLO. The TPLO principle is just to start with a medial incision of the medial part of the proximal tibia, and you are going to approach this proximal part of the tibia. You put your saw blade where you plan on the X-ray, and you start to cut with a specific saw blade to do a circular saw blade on a circular cut in the proximal part of the tibia. With a pin, you are going to rotate the proximal part of the tibial plateau to get a tibial plateau slope to 5 to 6 degrees. A temporary Kirchner wire could be used to avoid any motion of the proximal part of the tibial fragment, and you put your plate on the medial side of the stifle. We use locking screw in order to improve the stability of the construct and to be able to get to less risk of fracture, less risk of implant failure after a surgery. That's what you should get after that. The stifle should be at 5 degrees of tibial plateau slope, and the stifle will be very good motion and full stability in extension, in flexion, and in rotation also. This is the post-operative X-ray of Venus. You can see the cut. You can see the plate. We use a 3.5 broad plate in this dog because it's quite large Rottweiler, and you can see a picture of the surgery on the left of the screen. For the post-operative care, I just put some dressing on the wound to avoid any leakage from the dog. Put some non-steroidal during 2 to 3 weeks almost, and rest for 8 weeks. I think that physiotherapy is very important during the post-operative period. It's very interesting to get some to use cryotherapy during the post-operative period. There is some specific cryotherapy device which is very useful for the stifle, and that give you some compression, but also some cryotherapy, and that improve the outcome. It's the gold standard in human being, and I think that is very useful in the dog. And of course, physiotherapy is very important. You need to put your dog in rehab to get the best outcome you can get at the end of the surgery. What is the outcome and what is the prognosis of TPLO after cruciate disease? More or less, at 8 weeks post-op, there is a grade 1 madness for Venus, but the healing of the osteotomy is quite okay. You can see on this picture. At 6 months post-op, no more madness was described by the owner, and this is what you should get. The recovery with the TPLO is quite fast, and you can see that on this video, the dog is using his limb very fast. 1 day after the surgery, usually they use their limb just after the surgery, which is quite nice. But you need to get a very good pain management during the surgery, during the pre-operative and during the post-operative period, in order to get a very good outcome. At 3 weeks post-op, the dog are quite nice. They get more or less a grade 1 or get grade 2 lameness no more. And at 6 weeks post-op, you should get no more lameness at all with the TPLO. Yeah, we get more or less 80 to 90% of good outcome in our cases. So it's a very good surgery, really very predictable outcome, and I think that it's, as I say to you, the best surgery for the cruciate disease. Of course, it's kind of very it's quite a major surgery. You need to cut a bone, you need to put a plate, screws, so you could get some complication. Uh, when you've done a lot of TPLO, the complication rate is quite low, more or less 10%, and the major complication rates are quite low. The most frequent complication will be infection, I would say. Most of this infection is superficial, so it's just treated by antibiotics. But most of the time, you need to remove the plate at the end of the healing process of the bone. But you can also get some other complications, such as meniscal tear, which could arrive between between 2 to 3 months after the surgery, but sometimes maybe much more later. I get some cases where I get a meniscal tear almost 2 years after the surgery. Another complication, which is quite frequent but not a very big problem, is patellar tendinitis. Usually, it's just treated by medical rest and by non-steroidal. It's quite often to see this patellar tendinitis in the post-operative X-ray, but most of the time the outcome is quite good with patellar tendinitis just by rest and non-steroidal. The most complication, I would say, is implant failure or fracture of the construct. It's quite rare if you do a good surgery, if you use good implants. Usually, it's very rare to get any implant complication when you are doing a TPLO in a dog. I think that the most frequent outcome complication in dog with cruciate disease is the contralateral cruciate rupture in the on the other stifle. More or less, depending on the study, you will get 40 to 60% of your case with a contralateral rupture in 1 year after the first surgery. So you need to keep that in mind and to advise the owner that there is a risk of the rupture of the other on the other side. Well, if you get at time of the first diagnosis some synovitis and some osteoarthritis in the other stifle, I think that you will get a very high risk, more or less 70 to 80% of risk of rupture in the next couple of years. And it is also so that young age and increased tibial plateau slope will increase the risk of contralateral cruciate rupture. So be careful that this is for me the most frequent complication is rupture on the other side on the other cruciate on the other side of the dog. It's something that you need to explain to the owner. It's something that you need to keep in mind as soon as you are going to follow up your dogs with the TPLO. And of course, TPLO and CCL with CCL gets good outcome, but you also need to get a long-term treatment for the osteoarthritis. And I think that omega-3 is very important to give in order to decrease the progression of osteoarthritis, and also to reduce the risk of pain because of osteoarthritis. I would say that in conclusion, the CCL rupture is very common in dogs. The diagnosis is quite easy most of the time because based on the clinical examination and based on your on X-rays. In case of doubt, I think that you can go to MRI or arthroscopy, and at that time, TPLO is clearly the best surgery, and I always do a TPLO with a stifle arthroscopy to confirm the diagnosis, but also to evaluate the meniscus and to treat any meniscal tear during the time of diagnosis. I would say that I do more or less 5 to 6 TPLO every week, and I'm very confident with the surgery, and I think that TPLO is the gold standard of the cruciate rupture treatment. I think that perhaps I was quite fast. I would like to get 10 to 15 minutes to get any question from the field. If you want to see some video and to see perhaps some picture that you did not see well during the presentation, I'm here for you, and will be very happy to answer to any question. It will be a pleasure to have any exchange with you. Uh, so, do we get any question for the field?
Dr. Thibaut,
Yep.
there are
Do you
questions
hear
in the
me?
chat. Yeah. We can hear you. There are questions in the chat.
In the
Uh,
chat. Okay, let
yeah,
me saw
Dr.
that.
Ninad, there's a question from Dr. Ninad. Can the TPLO planning be done on digital radiograph processing software like CareStream, etc.? Like I think CareStream he has written. I think it is cesarean, something like that he means to say.
Okay.
CareStream.
I didn't understand clearly the question. Please, could you repeat? I didn't see the.
What he is asking is, can the
Ah,
TPLO planning be done on digital radiograph processing software like
okay.
Care?
Yeah, yes. Of course, you can use digital software to do the planning of the TPLO. Most of the software could be used for the TPLO planning. I use VPOP, which is quite nice because you can also put your plate on the X-ray, and you can get a very beautiful planning of your surgery. But I think that most of the software from X-ray software could be used for TPLO planning without any problem.
So
I'm
there's
sorry, I
a
did not see that you did not hear me very well, and because I perhaps speak a little too fast, I did not saw this on the chat. I'm so sorry for that. If you did not understand something,
I'll ask you, doctor. I'll ask you the
yeah,
questions. No worries.
yeah.
The second question is, hope Dr. Ninad, you have received your answer. Yeah. Dr. Pranali has asked the question like, with new implants and minimally invasive tools, where do you see TPLO evolving next?
Okay. I think that the next thing that we are going to move for the TPLO is to take care about the what we call pivot shift or internal rotation instability. And most of the time, at that time, I think that we are moving to combine extracapsular suture with what we call the internal brace with the TPLO, because the TPLO is very nice to avoid any cranial displacement of the tibia, but it's not very good to avoid internal rotation. And in case of very acute rupture with huge instability and with low osteoarthritis, you can get cranial displacement of the tibia, but also get internal rotation of the stifle. And the TPLO alone do not very well avoid the internal rotation. And I think that the next step for the TPLO is to combine extracapsular suture plus TPLO to get a full stability in full range in cranial instability, but also rotational instability. And perhaps also at the end, in the next couple of years, we are going to combine intracapsular repair done under arthroscopy with the TPLO, which is quite difficult because of the screws everywhere. Um, of course, I would say that the other thing that we need to look for the TPLO is to get the diagnosis as soon as possible, because we still get some dogs with misdiagnosis and with a lot of osteoarthritis, and which is not the best result we could get because of the osteoarthritis. So we are going to move to TPLO plus internal brace and perhaps a sooner diagnosis in order to get very low osteoarthritis at time of diagnosis.
Doctor, thank you for the answer. See, there are a few questions wherein they have asked, can you please cover angle measurement again? Again, there
Yeah,
is
of
another.
course.
Yeah, they have also asked post-operative bandaging video. So these two, can you address it again? Can you show it again?
Of course, I can do that just right now. Did you see my presentation?
Yes, it's visible.
Okay. The first step is to go to get a very beautiful lateral view of the tibia. You get a perfect lateral view when you see clearly well the superposition of the femoral condyle, and you get a very good, beautiful view of the tarsus. You are going first to draw the white line. Oh, sorry. the white line, which is the functional axis of the tibia. And this functional axis is coming from the center of the tarsus, which is just there, and the tibia eminence, which is just there. This is the functional axis of the tibia. Then we are going to draw the tibial plateau slope. For that, you take the cranial part of the tibial plateau, which is more or less where there is the attachment of the cranial cruciate, to the caudal part of the tibial plateau, which is more or less where the caudal cruciate attached to the tibia. And you draw a line between those 2 points. That will give you the tibial plateau slope. And the tibial plateau slope is based on the perpendicular to the functional axis of the dog, of the tibia. And you can see, if you go, I will show you again the video. Based on X-rays. Lines are drawn on the. You see that you are going to draw in the functional axis from the center of the tarsus to the tibial eminence. You draw the perpendicular to this line, and then the tibial plateau slope, which is the cranial attachment of the cruciate and the caudal attachment of the tibial of the cruciate, caudal cruciate on the caudal part of the tibial plateau. And this is the tibial plateau angle, which is in this cases 29 degrees. Is that okay for you?
I think that will suffice the answer. The next question is there any chance of patellar displacement after surgery?
You can get a fracture of the patella or fracture of the tibial crest, but there is no patellar modification, no modification of the position of the patella, because you don't touch the attachment of the tibial tuberosity. The tibial tuberosity won't move, so there is no modification of the position of the patella. If you can get modification of the position in the patella with a TTA, of course, but also with a cranial closing wedge or with the CBLO, where you are going to do your cut behind the tibial tuberosity attachment. So you are going to move the position of the attachment, so the position of the tibial, the patella will move into the trochlea. But with the TPLO, there is no risk of modification of the position of the patella.
Aligning to this, there is one more question. How would you position the patient during the TPLO surgery?
Usually, I put the patient in dorsal recurrency to do my arthroscopy, and then currently I keep the dog in dorsal recurrency to do the cut, but you can also move the dog in lateral position to get the cut in the from dorsal to from the more perpendicular to the table. Some depends of your preference. You can do the surgery in dorsal recurrency, but you can also put your dog in lateral recurrency to do your TPLO. But for the stifle exploration, I always put the dog in dorsal recurrency, and then you can move just after the arthroscopy on the lateral side.
Thank you for the answer, doctor. Now, next question is how much variation in tibial plateau angle correction to consider acceptable before it starts affecting post-operative limb function in dogs?
Okay, this is a very good question. There is a study, quite old one, which is about 10 or 15 years ago, that show that the outcome is not very different if you get a TPA after the surgery between 0 to 14 degrees. Nevertheless, I would say that as close to 5 to 6 degrees you are, the best stability of the stifle you get, and the less progression of osteoarthritis you get, and less risk of meniscal tear after surgery. So I'd like to get my TPA after surgery between 3 to 6 more or less degrees after surgery. Of course, if I am at 8 to 9, I don't go back to surgery. But you know, as soon as I think you are a little bit higher to 10, I would say that you should get perhaps a stifle instability, which is quite low instability, but you will get more osteoarthritis, more risk of meniscal tear after surgery. Now, based on this old study, you can say that up to 14 is still acceptable, but I think that we need to be as low as possible. Between 3 to 6 is just perfect.
Okay, thank you, doctor, for this answer. The next question is, considering that TPLO is primarily a canine technique, is there any research or adaptation of TPLO similar osteotomy techniques for foals or equine stifle injuries
Um,
in
I do some
horses?
TPLO. Yeah. I do some TPLO on cat. I never do it, and I never heard that there is any TPLO done on the horses. I I think that it could be perhaps possible, but you shouldn't get very large plates. But in human being, there is some surgery which is quite similar to the TPLO. It's not a clear TPLO. They call that a deflecting osteotomy. That they reduce the tibial plateau slope in some cases because it has been shown in human being that if you get a tibial plateau slope more than 12 degrees, you get more risk of injury of your reparation of your cruciate. So if there is a tibial plateau slope in more than 12 degrees, they decrease the tibial plateau slope at the time of the cruciate repair. But I have no idea of if TPLO has been done in a foal or in a kind. I see that in a small ruminant. I think that in sheep or in goat, someone do that, but I'm not sure that someone was already described in equine or foal. Sorry for that.
Uh, is physiotherapy sufficient for joint mobility, or is there any suggestion for it?
Uh, I would say that physiotherapy is clearly a good thing to do after the TPLO. And I give to the owner some advice to move the stifle as soon as possible to get some passive range of motion of the stifle as soon as possible. And I give them the advice to walk the dog 2 to 3 minutes every day during the first 6 to 8 weeks. Uh, and then to go to some specific exercise, for example, to put some figure of eight on when they are walking, to put the dog on small slope to get more weight on the hind limb, and of course, if the dog can go to a physiotherapy specialist, that's clearly better. But I'm not sure that is always mandatory. And I'd like to get some cryotherapy at the end of the surgery because it's quite easy to do and it's very useful for the outcome.
I think one more question is there. Uh, Yes. How do we decide between conservative management and TPLO in partial cruciate tears?
Ah, uh, that's a good question. I would say that in a partial tear, I do advise to go to TPLO in most of the cases because if you wait, you will get more osteoarthritis and you will get more risk of complete rupture at one time. So I would say that as soon as you get a meniscal tear, partial tear, that means that you get a lameness. That means that the dog is painful, and I will advise to go to a TPLO. Of course, if the dog is quite old, for example, 12 to 13 years old or something like that, in the large bred dogs, I would say that perhaps we can still keep on conservative management. But if the dog is quite old, 2 to 5 years old, I clearly advise to go to TPLO because the outcome will be better with less risk of osteoarthritis. So as soon as I get a diagnosis of partial tear, I advise to go to TPLO.
What late complications have you seen most often post TPLO, and how do you manage them?
Late complication, I would say
Yeah,
that
complications.
yeah, progression of osteoarthritis is still a complication of the TPLO, which is most of the time managed by medication. And you could also get in several months or year after the surgery. The most two late complication will be some infection, very superficial infection on the plate. Just have to remove the plate and it's okay. And in some cases, which is very rare, in long-term outcome, you can still get some meniscal tear. The lastest meniscal tear I get was 2 years after TPLO. I think that is the only one I get, but it's quite rare to get those meniscal tear so late after the surgery. I would say that osteoarthritis and infection are the most common late complication.
How to ensure rest for 8 weeks for post-operative care? Our patients are too agile as soon as the pain reduces.
Yeah. That's the other job, which is not so easy. I always say to the owner that it's clearly much easier. My job is much easier because the dog is sleeping, and the post-operative care is not so easy to take care. So I always give the owner advice to use only leash walk. The dogs should be on leash walk all the time for a few minutes, 3 times a day, no more. And if they are not on leash for the war, if they are, it's quite dangerous. And if they are not outside, I advise to put the dog in a small room or even in a cage just to avoid any too much activity. And it's some very active dog. I give some medication to reduce the activity of the dog. The first thing I give is gabapentin between at 20 milligrams every 2 to 3 days, 2 to 3 times a day, 20 milligrams by kilograms. And sometimes I also gives in very active dogs some acepromazine to be sure that the dog are quite in too much activity. But leash work is usually it's enough. Uh, on top of that, with the new plate and with the locking screws, I'm quite confident with the stability of the construct. So I only advise leash work, and if the dog is very active, some medication to sedate a little bit the dog.
One last question we will take.
Yeah.
What is the normal angle and from which angle it is best to consider for TPLO? Normal angle and the best angle.
Uh, I would say that the TPLO is the mean angle of the tibial plateau slope in dogs. In large breed dogs is 25 to 26 degrees. In small dogs, they are a little bit higher. That's 29 to 30 degrees, more or less. I would say that as soon as you get instability of the stifle, TPLO could be done, whatever the side of the tibial plateau slope. But you need to change and to adapt your surgery if you get very huge tibial plateau slope. I think that if you get more than 34 to yes, something that more than 34 degrees of tibial plateau slope, you need to adapt and to modify a little bit the TPLO to avoid any risk of tibial crest fracture, to avoid of any risk of implant failure. So I would say that between 15 to 34 degrees, TPLO standard would be enough. But in some cases with high TBI slope, with steep TPA, I would advise to modify a little bit the techniques to be able to correct the tibial plateau slope without any risk on the of fracture of the tibial crest after surgery. So in those cases, I do some modify closing wedge or TPLO plus closing wedge. That depends of the anatomy of the tibia, and that depends of how much TPA is. That's much more difficult surgery and more difficult to treat, more risk of complication. But with high TBI slope, you need to adapt a little bit the TPLO.
Doctor, one last one, because this
Okay, I'm
Dr.
still there.
Vinayak has asked one question. Do you monitor collateral cruciate rupture risk post TPLO? And if so, what preventive strategy do you use?
That's a good question. I think that when I'm doing a TPLO, I always do a X-ray from the opposite side, and as soon as I get some osteoarthritis and effusion on the contralateral side, I advise the owner to monitor any lameness and to see the dog every 6 months or something like that to see if there is increase of osteoarthritis or increase of lameness. As soon as there is increase of osteoarthritis or increase of lameness, I would say that we need to go to TPLO. And if you want to decrease the risk of rupture or progression of the of cruciate disease on the other limb, I would advise to the owner to get the dog as fit as possible, to be not overweight. That's the first step. Then to keep the dog with good musculation. So I keep an activity, but to start good activity, not too much also. But I'll also give the honor to advice to the owner to use some omega-3, perhaps to modulate a little bit the inflammation of the stifle, and to hope that there is less risk of contralateral rupture. But the first thing is weight control. That's the goal after the first surgery, to get a very fit dog.
Okay. Thank you, doctor. Thank you for the for answering all the questions which were asked by the participants. I request Mr. Purav.
Yeah, thank you, Seema. Would you just mind enabling me to start my video? I need the host permission.
Okay, I'll make you the host. Yeah. I think I've done it.
Perfect. Let me just that's it. Yeah. Well, that was great. Thank you so much, Dr. Thibaut. That was an amazing presentation on TPLO surgeries, and that was very kind of you to accept our invite and share your knowledge with the audience here. So really grateful and thankful to
Thank you so much for being there. I'm still apologize because I was a little bit too fast. I hope that everyone understood what I say. But there is a recording, so perhaps you can do the recording in a slow motion.
No, I'd say it should be all right. Yeah. That's no problem. But yeah, on behalf of TRM, my colleague Dermot, whom we have over here, and our partners, Vetina in India, we'd like to sincerely thank you for your valuable time and
thank you so much for the invitation. It's a pleasure to be there. I'm very proud to do this webinar with a large audience like that. It's cool.
That was great. So thank you so much. Really appreciate it. Thank you, Seema and Nishtha as well from Vetina.
Yeah, it was an excellent presentation.
Thank you so much.
One last this note from my side. On behalf of entire Purav, can you just make me host?
Oh, is it? Yeah.
Yeah.
Let me.
I need to put on my video.
Oh, well, okay. Let me just quickly go in participants. Seema. All these technical glitches are the modern day's problem. Yeah, you're the host now.
I have not received any. Yeah. Okay. Okay. So on behalf of entire team of Vetina, I sincerely thank Dr. Thibaut, who could spend his busiest time gracing his presence for the webinar. We also thank Mr. Purav Shah from TRM for coordinating with Vetina for this webinar, along with my colleague, Ms. Nishtha from Vetina. I thank all the wonderful participants for being a part of this webinar. And with this, I announce that the webinar is over. Thank you. Thank you, everyone. Have a nice time.
Thank you so much. See you. And there is my email on the presentation. If you need any question, please feel to ask to me. Thank you so much.
Thank you. Bye-bye. Bye-bye.